Welcome to today's Cancer Advocacy Committee meeting. I'm Julie Stokes, founder and CEO of Ellevate Louisiana. I'm a former state legislator and a cancer survivor. This committee builds on the work that began with SCAN, which was Survivors Cancer Action Network. We created that to give cancer patients and survivors a stronger voice in policy discussions. By bringing SCAN under the Ellevate umbrella, we've expanded that mission and created a broader platform to advance meaningful change for patients and families across Louisiana. Before we start, I want to recognize our incredible committee leadership. We have our chair, Kathy Oob, as well as our vice chairs, Terry Burkhoff and Julia Williams. I don't think Julia could be with us today, but we'll get to meet her in the coming months. These women have really dedicated their careers to advocating for cancer patients and survivors, and we're really grateful for their leadership. Well, today we are diving into an issue that affects many patients, the cost of prescription drugs and the growing scrutiny around pharmacy benefit managers, often referred to as PBMs. This topic has gained attention at both the state and national level, where it really seems to be thought of as by top leadership as something they're interested in making changes to. So I think on both levels, you can probably look to see some changes occurring soon. We're glad to be joined today by Dr. Madelaine Feldman and Pete Martinez, who will share their expertise on PBM accountability and reform efforts. Dr. Feldman is a rheumatologist with the Rheumatology Group in New Orleans. She's also the Vice President of Advocacy and Governmental Affairs and the immediate past president of the Coalition of State Rheumatology Organizations. She's a nationally recognized expert on formulary construction, drug pricing, and patient access to care. She's testified before Congress, state legislatures, the FTC, and international bodies. She's also taught at Tulane School of Medicine. Dr. Feldman has received numerous honors for her advocacy and leadership, and we're really honored to have her here with us today. Pete Martinez is a seasoned governmental affairs professional that I met right away when I got into the legislature. He's got more than 25 years of experience leading strategic campaigns and advocacy efforts across industries like healthcare, energy, and transportation. He's been called a powerful ally by the New York Times and a top operative by the Wall Street Journal for his work shaping policy and building coalitions at the state and national level. And Pete is the managing partner of Martinez Strategic Alliances. Dr. Feldman and Pete, thank you so much for being here with us today. And I'll hand it over to Maddie, Dr. Feldman. Maddie, as she likes to be called sometimes, to get us started.
It is a pleasure to be here, and thank you so much for giving me the opportunity to talk a little bit about pharmacy benefit managers. So let's get right into it. If you have any burning questions, you can stop me and ask. But I apologize if I'm a little bit too basic in times, and maybe not so basic. We'll just take it from the good, the bad, and the ugly. All right, so let's talk about pharmacy benefit managers and why should we really care about them? I give this talk to a lot of medical students, all the way up to fellows and heads of academics around the country. And a lot of people view health insurance sort of like that. And I'm hoping by the end of this, it's still not a big mess of spaghetti, but it can be. It's not as complex and complicated as people would like to make it seem like in order to sort of blunt reform efforts, but let's get into it. Now, this is very basic. We've got commercial and government. You've got the medical benefit and the pharmacy benefit. The medical benefit takes care of the provider care, hospital care, provider administered drugs. And so what we're going to concentrate on today are the pharmacy drugs, the ones that either come through a specialty pharmacy or mailed to you, or you go to your local drugstore and pick them up. And it started probably PBMs maybe with Medicaid, but they came into their own in the 90s. And we'll talk about how they've evolved over the years in terms of how powerful they've become and what they determine for certainly for my patients and for all of our healthcare. So this is sort of a very cursory kind of definition. They manage it for both health insurers, the government, the large employers, the state. Our state has switched PBMs a couple times. But probably the most important thing, and particularly how it affects drug prices, is they construct the formulary. Now, in terms of a few definitions, I think we all know the formulary is the list of drugs your insurance company will cover. They can tier them and put them on different levels. Utilization management tools, my bias is that they're there to maintain the profitability of the formulary, but I'll let you decide for yourself by the end of this. Some of these tools that they use to manage the formulary: step therapy, which is fail first, meaning my patients have to take a certain drug first, even if I don't think that's the best drug for them. Now, they could take another drug, but since we're talking about, we're going to talk about those expensive drugs, not the ones that, are generic and you can get without your insurance for a low price. So essentially, if they're not on the formulary, you're not going to be able to get them. Non-medical switching, and I'm going to tell you a couple of horror stories with non-medical switching. That's where a patient has to switch to a different drug for a totally non-medical reason, and usually it has to do with finances. And prior authorization, it's doctors and hospitals asking permission from the insurance companies to do either a particular procedure, see a particular patient, or take a particular drug. Now, I use the word price concession. Don't be fooled by PBMs when they say they bring down the price of drugs, because they don't. They don't bring down the price of drugs. What happens is they pay perhaps the list price, and then they get concessions sent back to them from the manufacturer in the form of either a rebate or a fee. And for a while, fees weren't that important. But one thing I want you to remember is that PBMs are usually about 5 years ahead of regulators and legislators. They can anticipate where the reform is going to happen. So they sort of knew that rebates were going to become uncovered at some point. There was going to be a certain amount of transparency. So they started reclassifying rebates as fees. And those, by contract, cannot be passed back to the client, whether the client's the state, whether the client's a large employer. They are kept by the PBM. And unfortunately, both the rebates and the fees, for the most part, are a percent of the list price. So you can see where the incentive comes in to have a higher priced drug. Okay, again, maintaining the profitability of the formulary. What the PBMs will they'll call them savings and lowest net cost. So if you make, let's just say, $100 on a drug as a PBM, and you make $50 on a different drug, which one is your lowest net cost? Obviously, the one you make the most money on. So you have to be very careful about the terms that they use. Savings to the healthcare system, oftentimes they're referring to themselves as the healthcare system. So utilization management tools, we start with prior authorization. Again, as I said, it started off, I think, probably like most policies, the unintended consequences end up taking over, but it started off as a good thing. You wanted to make sure that, improper, either whether it's tests or surgeries or medications, but as the years have gone on, the prior authorization has become ridiculous. I mean, I'm a rheumatologist, and even though we try not to use steroids, prednisone very much, occasionally we do, probably the cheapest drug out there, they actually have prior auths put in where my patient has to fail a more expensive drug before I can even give them a 5-day supply of prednisone. I mean, that tells you where the harm is coming and where's the motivation for a prior auth like that. Then we have step therapy. And step therapy, I mean, Louisiana re-upped its step therapy bill a few years back that I actually testified on. And we have a pretty good step therapy bill here in Louisiana. One of I think the most important things is that if a patient is stable on a drug and it has been covered by their insurance, that they have to be able to stay on that drug at the same cost share. And that is a really important aspect. We don't have step therapy reform nationally for large ERISA plans for the self-insured employers yet. There is the Safe Step Act that's been waiting to be passed for years. We're hoping in the coming years that we will have that. Non-medical switching. About a month ago, I was asked to sort of MC an interview with some parents. Their son Cole had asthma since he was born. He was 22 and had been on the same inhaler for about 5 or 6 years, went every month to his Walgreens to pick it up. He went to go pick it up and they said, "I'm sorry, that's no longer covered on your insurance." He wasn't told, his parents weren't told, his doctor wasn't told. It would now cost him $550. So he left. He didn't have $550 to pick up that. He did have his roommate there, and so he and his roommate went back. 2 days later, he went into status asthmaticus. If you don't know what that is, it's an asthma attack that doesn't go away. His roommate put him in the car, and by the time he had been without oxygen long enough that by the time he got to the hospital, he was brain dead. This was completely avoided, could have been avoided. He died 2 days later, and I interviewed his parents at a national healthcare summit in Las Vegas about a month ago. Let me tell you, the Kleenex boxes were out. Unbelievable. And it turned out his parents didn't even know until, the second day in the ICU that his roommate told them, he didn't have his inhaler. And so they've sued United Healthcare. I mean, they have really brought this non-medical switching really to the national forefront. I had testified before a non-medical switching bill in Illinois, and a young girl had her seizure medicine switched on her. And she lost her entire year as she started having more and more seizures. So this is not something that's just, oh, it's an inconvenience. Non-medical switching can be deadly. And I found out from some other panelists in Las Vegas that Cole wasn't the only one that died from non-medical switching that year from asthma. 35 people from one insurance company. And they can change 3 and 4 times a year unless you pass legislation saying they can't. I mean, at least pass so that the doctor knows and the patient knows. So a few years ago, I co-authored a white paper on the impact of step therapy on patients, and I'm not going to go into everything on it, but basically it was survey data. We interviewed patients, pharmacists, physicians, and payers, and these are some of the issues that patients talked about from step therapy, meaning they couldn't get on the drug that they need. When you ask them about what is that one important thing in your life, did step therapy affect that? Yes, they couldn't hold their grandchild. They couldn't walk their daughter down the aisle. These are things that are, you can't put a dollar sign on them. So step therapy, when insurance companies and PBM say, oh, there's really no impact, there's significant impact. And I've seen it in patients time after time after time. And then this again is non-medical switching. It's ridiculous. It's such an easy thing to fix. You sign up for a particular health plan. You think your drug is covered. 3 months later, all of a sudden it's off. This happened with a certain blood thinner in atrial fibrillation a few years back. Strokes, deaths, recurrent, bleeding, things like that happened. And when the PBM actually put the original blood thinner back on the formulary, they didn't notify anyone. So no one even knew that it was back on the formulary. So what do they do in addition to constructing the formulary? This is why they came about, was to adjudicate the pharmacy claims. The medical side really doesn't want to handle that. They're busy handling paying doctors, paying hospitals, those kinds of things. They didn't want to adjudicate those pharmacy claims. Take them in, figure out how much the medication is going to cost, who's going to pay for it, where can they pick it up. So they determine, if you really think about it, what drugs my patients can take by constructing the formulary, when they can take them through utilization management tools. You have to take this one first and this one. Nope, can't ever get that one. That one's been excluded. You can take this one, but it's going to cost you more. When they can take it, where they can pick it up, and how much they're going to pay for it. I mean, if this is power, this is true power. They control all of this. and three PBMs control 80% for the American people. I'm sure you probably know who they are, but I'm going to tell you. This was back in 2019. This is a sort of a slide that Adam Fine, who runs Drug Channels, puts out every year. Here we have the big three: United, Aetna, and Cigna. Optum Rx. United always had, I think Catamaran was their original PBM years ago. In 2019 is when this true vertical integration between the medical the medical companies, became sort of integrated with, bought or was bought by. So CVS Caremark, before CVS Health, before they bought Aetna, Caremark made all the money. Back then, it wasn't their specialty pharmacy. It certainly wasn't their pharmacies around the country. The PBM managed to cobble together around $80 billion to buy Aetna. It took the Department of Justice about a year to okay that purchase, but they did, and I'm wondering if they look back on it, if they regret it. And then Express Scripts has always been in like 15, 16, 17 on the Fortune 500 as just a company that doesn't do any research, doesn't make any products, doesn't take hold of any products. All they do are those setting up the formularies and determining the what, when, where, and how much. And they're money makers. So Cigna said, I want one. So they purchased one in 2019. So now we have the big three either owning their medical insurance company or the medical insurance company. And what has happened since then? Oops. There is a lot more companies that come under these big three. I want to draw your attention to Ascent, Zinc, and MSR. These came around, I started hearing about them maybe 5 years ago. And once again, this is the PBM thinking ahead. How can we hide the rebates? Because when they sit in front of Congress and say, we pass 95% of all the rebates that we get back to our clients, how much do they get? And how much is kept offshore in their rebate aggregator? Well, that we don't know. So when we pass this rebate pass-through legislation, it's got to be clear how much is being kept in Switzerland in Ascent, how much is being kept in Ireland with MSR, and in Zinc here in the United States. The next thing that's kind of interesting is they now make drugs. The big three all have their own manufacturing line. They don't actually make the drug, but they white label it, and now they make money on the sale of the drug. Those of you who are old enough can maybe remember back in the 90s, Merck, a manufacturer, owned Medco, a PBM. Federal Trade Commission came along and said, you can't do that. You can't make the drug and then prefer your drug on the formulary. That is anti-competitive, and they sent a sort of a consent decree to them and said, you can't, unless you want to make it a totally open formulary. So they essentially put the kibosh on manufacturers owning a PBM. Here we have three manufacturers, Quallent, Cordavis, and Nuvela, owning PBMs. They're certainly being a subsidiary of a PBM. Now, I've spoken to the Federal Trade Commission, but as you know, they're kind of up in arms now. They have their PBM investigation going on, but all kinds of other upheavals. But this is something that should be no more legal than Merck owning a PBM back in the 90s. And yeah, they make a lot of money. United Healthcare, I occasionally will listen to their earnings calls, and it's obscene, the amount of profit, maybe $5-6 billion a quarter. I mean, and yet they deny rehab for people, Medicare beneficiaries coming out of the hospital. They deny drugs. They move patients. It's
Mm,
uh,
it's heartbreaking.
yeah, it is. It's heartbreaking. So one thing you have to remember, and why there's so much competition to get on the formulary for expensive drugs, because if you have an expensive drug and you're not on the formulary, I don't care how great it is, no one's going to take it unless you give it away for free. So the competition, every time I testify, even before state legislatures, well, no, competition always raises prices. Well, that doesn't really happen. Well, I'll show you what really happens. I don't want to let the manufacturers off the hook, because I don't know whether you want to use the word cahoots, but they have somehow agreed to this system. So the PBMs point the finger at the manufacturers and they say, they set the prices. And then the manufacturers point back to the PBMs, they make us raise the prices. And actually, both of those are true, but it creates this smoke and mirrors that you just kind of can't get through and creates this idea that this is all so complex. How are we ever going to be able to reform this? We have, and it's in little bits and pieces. And now this is, I'm not going to make you look at this as it's nowhere near an immunology slide, but I want you to just concentrate on that relationship between the manufacturer and the PBM. And I put it in very simple terms. Manufacturers get placement on the formulary in return for rebates and kickbacks. And I've been writing on this stuff for about probably almost 10 years now. And I used to feel bad about calling them kickbacks. And my son's an attorney. He goes, Mom, look, they wouldn't need safe harbor from the anti-kickback statute if they weren't a kickback. So, okay, so they're safe harbored kickbacks. The federal government in its wisdom gave safe harbor to insurance companies and PBMs and a number of folks from these kickbacks, but it has really led to the drug pricing crisis that I'd like to call a formulary construction crisis. So what determines preferred placement? Preferred placement, let me tell you, for a manufacturer is great because patients have to take your drug first. You cough up more money, the PBMs will switch everybody from one drug over to your drug. Sometimes even the other medications that you make, if you've got clout with the PBM by making them a lot of money, sometimes they'll even put a drug that maybe doesn't have anything to do as far as my patients are concerned. It might be a GI drug. It gets preferred placement as well. Is it based on the safety of the drug? Is it based on how well it works? Maybe it's the lowest list price because we keep talking about drug pricing crisis. This might be the lowest list price. No, guess again. There's a bidding war. And what are those bids? I'm gonna refer to them as rebates, but it's a lot more than just rebates. Here's the equation. The list price times the percent rebated. And we all remember back in algebra, if you increase any one of these variables, the result is a higher amount. So if you have a $1,000 a month drug and I promise to give back 50% to the PBM, they make $500. If I have a $2,000 a month drug and I promise to give back 50%, they make $1,000. Which drug do you think they're going to choose? I have seen, because I was sent a recording of a pharmacy tech from one of the big three PBMs trying to explain to an employer consultant why they had Zytiga, $10,000 a month metastatic prostate cancer on the formulary, and the $350 generic was totally excluded. And he goes, I'm not sure why they do this, but we do this with a lot of drugs. And he started naming them off, and she recorded it and sent the recording to me. And he said, she said, what if the doctor wants the patient to have the 350? Well, they can appeal the denial, but the patient will end up spending more money on the generic than on the 10,000. Tell me, how is an employer going to save more money on a $10,000 drug as opposed to a 350? I don't care if they get a 50% rebate. They're still going to be paying $5,000 a month. So what about competition? If you're building a house and all the contractors are saying no one's your sister's brother-in-law's cousin's boyfriend, and the quality is all the same, the more people bidding on it, competition brings the prices down, and the winner tends to be the lowest bidder, at least in theory. However, if you're selling your house and everybody wants your house, competition drives the price up, and the winner is the highest bidder. Guess which kind of competition our drug distribution system relies on? Yep, it's the old selling the house. Rebate bids are a percent of the list price. And now, I can tell you a story where Eli Lilly gave their insulin to the Express Scripts back in the day. And Express Scripts said, we're not going to let Novolog on the formulary. Humalog, which is your product, will be the only one if you give us a 100% rebate. And Lilly did it. They turned around and charged the patients on the full price of the drug. So I don't want to hear, and Lilly made no money on it. Now, again, I don't feel bad. Lilly's a winner in the rebate game. Not so much in the rheumatoid arthritis game. They lost out to AbbVie and Amgen. But it is a perverse incentive to put higher priced drugs, not lower priced drugs. And remember, it's the fees. So let's calculate savings the PBM way. Two identical dresses, one at 1,000, the other at 100. Same dress. Both are offered at 50% off. Which dress do you save the most money on? Which would they pick for their dress formulary? The $1,000 dress, because it saves more money. You know, one, you save $500. The other one, you save 50. You see how they twist that. So this whole thing about savings for the healthcare system, I don't want to know how much money you saved. I want to know how much the employer paid for the drug. So the higher the price, the higher the rebates, the higher the fees. And now the specialty pharmacy has sort of come into its own, which is why CVS Caremark was kicking and screaming on the divestiture bill last session. They're owned by the PBMs. They set the prices of the specialty drugs. There was a blood cancer, GI cancer drug called Gleevec that it went generic in around 2017, 2018. It stayed at $6,000 a month after going generic because the specialty pharmacy decided what a specialty drug was and they decide the price. It wasn't until, and I'm not a advertiser for Mark Cuban, but it wasn't until Cost Plus Drugs came in in 2021 that the price of imatinib came down to $40. And there were still specialty pharmacists selling them to employers for $5,000, $6,000, the same drug. They make
Gosh.
money on fulfillment. And so there is a very expensive rheumatoid arthritis drug called Xeljanz that's going generic next year, a Pfizer drug. And it's a small molecule, it's not a biologic. I'll be curious to see if the $75,000 a year stays, as if it goes to the specialty pharmacies. So the higher the price, the higher the PBM profits, but unfortunately, the higher the out-of-pocket costs for all patients because these expensive drugs tend to be co-insurance, and you're going to find fewer and fewer drugs with co-pays and more with co-insurance. And I'll leave you, this is the last slide, showing you where the profits from PBMs have gone from 27% profit from rebates down to 7%. So passing rebates through, they've reclassified those as fees, so many fees that it's small pickings at this point. Where 15% from fees now up to almost 30%. But it's this is where the money is. This is why they don't want to be divested from their pharmacies, because 36% of PBM's profits now come from specialty pharmacy. I imagine them sitting around in the boardroom. Let's never forget that the public's desire for transparency has to be balanced by our need for concealment. And at the end, I will be happy to take any questions.
So a couple of seconds ago, really, you said fewer and fewer drugs will have co-pays and more will have co-insurance instead. And is that just that it's more advantageous and they're resetting policy for that or what?
Yeah, as you look at, and there are charts on that. Yeah, because if you're choosing a higher priced drug, a copay, maybe the highest copay would be $150. But co-insurance, it's usually around 20%. And because we now have pharmacy deductibles, those deductibles can be very high. So you're stuck paying, could be, I remember where $2,000 used to be a high deductible. That's a low deductible now. $5,000, $10,000, and certainly with some of the ACA plans, they can go up even higher. And that's why, the copay cards have always been so important for, the non-governmental insurance is because it went towards the deductible. And Louisiana, again, I testified for that one, and justly so, banned copay accumulators. They still have maximizers, which still take away the ability of the copay cards to count towards the deductible, but at least patients don't lose their medications. I don't want to
Could
take
you
up more.
explain
Yeah, go ahead.
could you explain the copay accumulator and maximizer a bit?
Sure. Okay, so what came out first, and I envisioned because PBMs didn't like people using copay cards. Somehow they thought it wasn't fair. You don't get a copay card for the medical side. No, you don't, but you get a discount. Blue Cross negotiates discounts on the medical side, and you pay your cost share on the discount. There are no discounts on the pharmacy side, I can tell you that. So that whole argument went on the wayside. But they wanted to figure out a way that they could make money on copay cards. So they said, let's just not let them count towards the let's let them not count towards the deductible. But the problem was when the patient's copay card ran out, like say in June, and they go to pick up one of my drugs like Humira, they go, well, that'll be $2,500. What? But you just got $5,000 from the copay card. Well, no, I'm sorry, that doesn't count. We want the money from that, and we want the money from you. It's like, going and buying a car and your parents are giving you some of the money and the dealership says, okay, we'll take your parents' money, but we're not going to count it towards how much you have to give us for the car. I mean, it was ridiculous. So in its wisdom, Louisiana passed a ban. So they figured out, well, how can we get around, because it had very bad PR, because people would lose access to their drug when that copay card ran out. So they said, well, how can we get rid of the bad PR, but still keep those copay cards? So they started something called a maximizer. And what they would do is they would take the copay card, they'd threaten the patient by, if you don't sign up for our handy dandy, it was a teacher that I first learned about it in 2018, Maximizer Save on SP plan. You're going to have to pay the full price of the drug, and it's not going to count towards your deductible. But if you give us that copay card, we'll take it and amortize it over the year, so you'll never lose access to the drug. Well, their out-of-pocket cost maximum might have been $5,000, and you got a copay card that's worth $20,000. They take and use up all of the $20,000 from, they maximize the value of the copay card, and then the patient is still stuck paying their pharmacy deductible. So the difference is, one, patient loses access to the drug when the copay card runs out. The second one, they maximize it, and actually they could take quadruple the amount of what the deductible would have been. And if they don't know the value of the maximizer, I know there was one PBM in particular that would put forth false claims every month, put in a claim that wasn't true to see if there was any money left on the copay card, so they could use that money and say, I'm sorry, we've changed your maximum out of pocket. So passing legislation that doesn't allow them to change the plan during the year could help with, reducing the abuse of maximizers. I hope that's clear.
Yeah, I'm probably gonna have to consult with you again. But yeah, 'cause, I mean, that's one of the things that ultimately we're looking for, is legislation that might be something that we think we can be part of to kind of move the needle on these things.
I
So
mean,
it sounds like
people,
there's some fertile ground there.
and with premiums going up and deductibles going up, getting that deductible paid for. I mean, I just saw an article, a patient who has like a $15,000 deductible, they can go into medical bankruptcy with a stubbed toe, particularly if you end up going to the emergency room, and nothing gets covered. And 15, what is it? 80% of the population doesn't have $400 that they can just find and pay for something.
Right.
So
Right.
it would be very helpful if we're trying to lower out-of-pocket costs for patients across the board. Let the copay cards count towards deductible. I will tell you, and this is a story, because I had lectured at the American College of Rheumatology to fellows, and one of them was becoming an attendant at Yale in the rheumatology section. And he said, Dr. Feldman, can I, keep in touch with you? I'm interested in advocacy. And he emailed me a few weeks later and said, I'm not going to name the name of the PBM, but the chief medical director of one of the top 3 PBMs was coming to Yale to discuss. This was back in 2018, 2019. And I said, ask them if they're going to put a copay accumulator in their PBM formulary. This was before they were copay accumulators were well known. And he said, yes. And I said, and ask them why. And this chief medical director said, and I choke up every time I hear it, those people, anytime you start something with those people who pay so little in premiums, don't deserve to have their deductible covered. I don't know if he ever said that again, but that is the attitude of health insurance companies towards people who are poor and can't, they have to get, low premium, so they have a deductible, and they're on an expensive medicine. They still use, they don't have enough skin in the game. So you have MS, you have lupus, you have cancer, you have ulcerative colitis. That's not enough skin in the game. Don't get me
Yeah.
started.
Yeah. Wow. Yeah. So, one of the things, and then I want to hear from Pete, but that I think about all the time. And I'm just always trying to figure out how I actually feel about it. In self-funded plans, you can't really legislate with regard to them, so you can't fix so many things. Do they handle these accumulators and maximizers differently, and are there
I
different rules?
I can tell you the employers have been, I don't want to say hoodwinked by PBMs, but what has happened is if you don't put, because I've talked to some of the transparent PBMs who've tried to get contracts with larger employers, if you don't put a maximizer in the plan, then the numbers just never work out. The PBMs have gotten, I guess, the employers so used to the maximizers bringing down the cost in other areas that if you don't have a maximizer, you can't compete to get the contract with a large employer. And that's a shame, because they're hoodwinked. And I mean, I could go on and on. I've got so many stories about large employers getting hoodwinked by PBMs that could actually end up getting them sued for breach of fiduciary duty because of charging, making the patients pay more. The one thing we have to remember, and my son keeps reminding me of this, that all of our health insurance companies are publicly traded, and their fiduciary responsibility is to their shareholder. He would go, Mom, not to your patients. And I said, we have chosen as a country to take, it may be public utility, where you can make a profit, but it only goes back to paying, sort of your staff, et cetera, et cetera. Because otherwise, they they're doing what they're supposed to do, and that's to keep their stock price up. I interviewed Wendell Potter, who was an executive with Cigna. He was their chief communications officer, and he left because he couldn't take it anymore. And he told me, he said, Madelaine, insurance companies are there to make a profit. They view physicians, providers, and patients as a means to make money. That's how they view us. I don't care what their mission says on their website. That's how they view us. And I'm sure it's the same with the manufacturers. But we pay a lot of money for health insurance, and it's not health care. And
Well,
but
what you
Pete,
said
it's
about them
Pete's
being
turn.
Yeah, because what you said about them being kind of like, public utilities, I mean, that's what departments of insurance are for states to be able to regulate them. But, so many employers are self-funded plans now that nobody can regulate them. Yeah, and that
And
that
Department of Labor is so understaffed and overworked. They everything from, alternative funders and to actually, it's so funny when I hear the term ERISA protections. I feel like they have less protections than folks. Um, Maybe the insurance companies have protections, and I understand large employers, but they're struggling to meet the healthcare costs.
Well,
Um,
and they're not all larger employers. We were approached we didn't do it, but we were approached when we had 22 people. So,
yeah,
you know,
all it takes is one, that reinsurance, the stopgap insurance, that stuff is very
yeah,
expensive now.
yeah.
Pete.
I'm happy to jump in, Julie. Now's a good time.
Yeah, that'd be great, Pete. It's so good to have you here.
Yeah, thanks for having me. I think I was kind of asked to just sort of kind of give an overview of where are we in Louisiana with this entire discussion. And so I think it's probably helpful just to go back to the previous session and kind of go through the topics. A lot of what Dr. Feldman covered was considered by the legislature. So I kind of want to go sort of the way it unfolded in the legislature and then kind of tell you where we are in that discussion now. And I think that's probably the best entry point of where your group goes forward with kind of taking a look at this. So there were several bills that were filed last session. Senator Jackson Andrews had one that was around pharmacy reimbursement, one of the groups that has been highly critical of PBMs across the country and certainly in Louisiana has been independent pharmacy. They have concerns with the way that they've been reimbursed, among other things, patient steering, to where we talked about the vertical integration of these healthcare companies, and so one of the concerns that they've been raising with lawmakers for a long time is that as independents, their patients may be steered away for a particular drug or for their entire business to a PBM-owned pharmacy rather than the local, old Rexall drugstore or wherever they are in Louisiana. So that is something that a lot of lawmakers hear a lot from, and from all over the state. And so that was part of the genesis of Senator Jackson's bill, was in part to kind of look at how pharmacies are reimbursed with this on their end of the equation with PBMs. Another bill dealing with the rebate piece was House Bill 264 by Representative Eccles. And that one sort of slowly moved through the process, and it started out as a rebate pass-through bill. And I'm going to mention another bill, and then I'm going to come back to the Eccles bill, because it became one of the major instruments that was considered. So another bill filed was Senate Bill 194 by Senator Jimmy Harris, and that's one that we would call a delinking bill. That bill sought to kind of change define fees and rebates in a more robust way. Dr. Feldman mentioned that there's some games that can be played with what's a rebate, what's a fee, and where does that fall. And so what that bill tried to do is capture that entire universe and define rebates and fees, and then also change the way that the PBMs were the way that they were compensated. So rather than based on the price of a medication, we talked about that $1,000 versus a $500 and 50% off each one that we just discussed. Rather than go through that model, it would put forward a model where the PBMs would be reimbursed on more of a standard fee model across. So regardless of the cost of the drug, they're compensated for that transaction outside of the price. So the idea being that would change this model and eventually try to bring down or do away with this perverse incentive that sometimes puts a more expensive drug as a preferred drug rather than maybe the one that would be cheaper. So that was the Harris model. So I want to go back to those are what were filed, and then even the most controversial one came a little bit later, and I'll get to that one as well. But I want to talk about Representative Eccles' bill, because it's the one that eventually passed, and that bill took that rebate pass-through model, also became a vehicle for some of the concerns that were raised in Senator Jackson's bill. That had been heard by the Senate Insurance Committee, and the Senate Insurance Committee ultimately became the body within the body that really dug deep on this issue. And Senator Talbot, who chairs that committee, tasked Senator Adam Bass to really kind of be the point person on the entire discussion. So Senator Bass, along with a number of members of the legislature, held ongoing meetings throughout the kind of the latter half of the session once that Eccles bill got to that committee, knowing that bill would be the vehicle for this entire discussion. So that was this kind of, if you look at the pharmaceutical supply chain, whether that was the manufacturers, the PBMs, the health insurers, ERISA plans, the CSRO on behalf of the physicians, and a number of other folks were all sitting around the table. Sometimes it was a circular firing squad. That's how these discussions go for those of us that have been around these discussions for years. And this discussion was not unlike that. The one, I think, big driver, though, was that Governor Landry was really charging to do something in this space. And there was support from the governor's office to say, hey, something's not right here. let's move forward with legislation. And so there was some pressure from the governor's office to do that, and he was, quite outspoken on trying to do something about what he recognized as an issue with PBMs. All that came to a head as that piece of legislation was eventually sort of a compromise. Compromise, probably the wrong word. But from that discussion came forward a set of amendments. And I would tell you, I don't think that any individual member of that circular firing squad was probably completely happy with the outcome. But I do believe that it moved the needle forward, at least in trying to deal with some of the questions that have been raised by independent pharmacists about steering of patients, some around definitions of specialty drug and how that could play into overall pharmacy cost. And then also the bill dealt with the pharmacy reimbursement issues that they had and put forward a new model for their reimbursement as independent pharmacists. So it did take care of some of their concerns there. So that bill did make it through the process. At the same time, right as that was about to be finally considered by the House, and there was another bill, House Bill 358 by Representative Dustin Miller, who chairs the Health Committee in the House. His bill started out as a pharmacy tech bill, but became through a conference committee report, basically a large amendment, what we would call a vertical integration or a divestiture bill. And that had to do with pharmacy ownership by PBMs. And so that was probably the one where you started to see a very robust news cycle within the last couple of weeks of the session. A very similar piece of legislation had just passed in Arkansas at that time and had been signed into law by Governor Huckabee Sanders. And so it was another bill that was being pushed strongly by the governor's office to try to do what Arkansas did. At that same time, I think lawmakers were hearing from colleagues in Arkansas, and that there was some questions about, well, if you prevent, and basically what the bill did is that it would prevent the licensure of a pharmacy owned by a PBM. And so that took that. Especially in the case of a CVS, where they've got pharmacy locations all over the state. The question was, could they continue to be in business? That was the question that they raised a lot, spent a lot of money on advertising and a pretty robust lobbying effort to say that, that you're going to actually hurt pharmacy access in the state. That's a question I think that still has to be considered by the legislature as they move forward, but it was certainly, in the very short amount of time, it was an effective question that was raised. And ultimately the Senate basically hit a pause button on the conversation at that point. They let the bill that was dealing with pharmacy reimbursement move forward, but the concerns around, is this going to cause some pharmacies to close? And by doing that, especially with some of the large employers who are tied to CVS plans, is that going to really cut access? Dr. Feldman and I could probably argue the other side of that as well, but I'll just kind of tell you where the legislature, where they're, I think, a fair assessment of their mindset was, well, hang on, we need to look at this a little closer. And so what they did was they passed a resolution on the final day of the session to say, in the interim, we need to look at this and study it. So there's an ongoing study that's going on by the Louisiana Department of Health. They're the lead on it, with some other input coming from the Department of Insurance and others. And then there's also part of the Eccles legislation that did pass had some revisions to an existing PBM oversight committee. And so that's been reconstituted, and they're having hearings, which brings us to where we are today. There has been an initial meeting of that oversight group. They met in September, and these types of meetings, for those of y'all who've been around the legislature for a while, know that they kind of do an organizational meeting first. It was very much that, but they also heard a pretty engaging presentation from Cost Plus Drugs, the group, Mark Cuban's group. And so they that sparked a fair amount of conversation around access and affordability of medications, but that's kind of where the conversation stopped there. There will be another hearing. The legislature is expected to come back in at the end of the month for a special session, and while that will involve two committees dealing with redistricting and elections and those sorts of issues, the rest of the legislature is going to have time on its hands. So the thought being that Senator Bass is going to move forward with holding another hearing while the lawmakers are in town, and they're going to hear input from a lot of those players that have been in that discussion, the third party group. So they'll hear from those three major PBMs that control roughly 80% of the marketplace. There will be the manufacturers will have a presentation that they will make, and then CSRO.
I wish I could be in town. Unfortunately, I will be in DC because that's the one thing that I really did want to. So I tried to find someone good in Baton Rouge, and Pete, you may need to chat with him a little bit. I know we're going to give him a script and everything, but.
Well, yeah, Dr. Neshwaite here in Baton Rouge is going to be there to present to that committee and give the physician viewpoint. And so basically what the committee's doing right now is sort of taking all this input, right? And at the same time, there's another effort under the Department of Health that will eventually produce a report that the legislature will have as they go back into session next spring to consider these issues again. And the vertical integration, the divestiture piece, that could be part of it. I think the delinking piece will be part of it again. I mean, all those issues that were there last year, they haven't gone away. You also have a regular session, so you have the ability, legislators aren't limited to a small amount of bills that they can file. So you'll have a much larger discussion around all this. But I think with the efforts that they're doing right now will give at least the key players in these that are heading these committees and are sort of the legislators and kind of that have been tasked with being in charge of the issue. Julie, you know how this works. You have several people that get really informed on any particular issue, and their colleagues rely on them a lot to kind of become experts in that. And that's what they're doing right now. They're trying to learn from people like Feldman and other players within this space. What does all this mean? Because giving legislators a little grace, they don't do deep dives necessarily in their day job to do this. So there's got to be a little bit of time to kind of even just get up on the nomenclature. I mean, one of the things that we've done is pull together a glossary, right? Because terms like vertical integration can mean something different to 2 or 3 of the 4 or 5 players that are sitting around the same table. So trying to get a common space to even have language around, common language around the debate, I think is helpful. And it's one of the things that we're trying to do to provide legislators at least that we're singing from the same hymnal. We may end up with a different response, from the song, but at least, we're always kind of starting from the same part of the conversation. So we're not getting lost in that. I will, tell you that the speed at which these things were being considered at the end of the session, it was at the same time that you had budget bills and all the other things that the legislature has to consider. It was a pretty large download in a very short amount of time for those members. And I think that's ultimately why the Senate was like, let's pause, get a better handle on this. We still got 2 years left in the term. As much as a lot of us would like to see action in this space, that's sometimes the legislature does that, and to try to get, especially with something that could be confusing. And I think where they thought they needed to at least understand what is this threat of pharmacy closure, does that actually impact access to medications? Because I think regardless of which pharmacy it may be, I don't think the legislature is trying to necessarily put their thumb on the scale there. But to the extent that some patients may have, I don't think they wanted to put themselves in a position to where they may have taken an action that inadvertently made somebody not be able to pick up their meds, right? That's not
Totally.
Yeah, I mean, Pete, I
So-
think they have a valid argument. You know, when I think about it in terms of my patients, and I'm actually on a specialty drug from CVS Caremark. I'm one of the ones that got that email saying you may lose. I don't think I would lose access to the drug, but I think I definitely don't like PBM zoning specialty pharmacies, but there would have to be a graduated kind of withdrawal, because I do think it would create a little bit of havoc to just sort of make them all. And there's a lot of lawsuits going on as well. So that it would probably be sitting in the courts for years as well.
What
right.
was the name of that committee, Pete, that you were talking about? That and when will they be meeting?
The PBM oversight hearing, I don't have a specific time yet. It's supposed to be the week of October 26th. So it should come out pretty soon. I think
I mean,
probably,
they said it was the 27th, because
I'm
if
sorry,
it's not the
20
27th, if that's not the date it's happening and it's happening later in that week,
we
I'll
just
be
haven't
out.
we haven't gotten a final. Part of it is I think they're also the organizers of that committee also have to kind of figure out what's going on with the those rooms that may be used for the special session. So I think as soon as we get a call from the governor, which we expect any time now, on calling the legislature back into session, those things will then probably drop in terms of finalization of schedule, so committee times and all that. So there should be an announcement forthcoming.
Dr. Feldman, Pete, thank you so much for sharing your time and expertise with us today. You guys have been amazing advocates in this space, and your knowledge is just really striking, and I appreciate both of you. And thank you to all of you who are out there listening. You know, conversations like this are exactly why we created this committee, to bring together advocates and providers and policy leaders to tackle the real challenges that are out there facing everybody, but cancer patients and survivors in Louisiana. So we really appreciate everybody's time today. If you're interested in these types of policy talks, check us out on Ellevate Louisiana's website, where you can learn more about our events, our policy committees, advocacy efforts, and how to join. That website is ellevatela.org, ELLEVATELA.org. If you enjoyed this episode, don't forget to subscribe, leave a review, and share it with someone who needs to hear it.